Okay, that's what happens always. So next we would like to introduce the chairperson for this session, Dr. Nahida Ahmed. And I don't think I need to go through yours.
Assalamu alaikum, everybody. Again, thank you for joining us after the coffee break. I hope you've had a refreshing break, and we are looking forward to getting started with our next session. And it's my privilege, honestly, to be presenting. Like they say, it's, teamwork is dream work. I'm really, really fortunate that the next presenter is a team member of mine at Department of Health, and I couldn't be more privileged to work with a better team than her. So it gives me really great joy to introduce Her Highness Sheikh Modi Al Nahyan, Dr. Modi Al Nahyan, to present Abu Dhabi's strategy and highlight on our achievements so far. Please give a big hand to Dr. Modi.
Assalamu alaikum. I hope you all are still awake after this coffee break. I'm not a physician. I am a physician, but I'm not a psychiatrist. I'm not a psychologist, but I have a medical background. So I'm working in the Department of Health, which is a regulatory body of the Emirate of Abu Dhabi, as the Director of Health Facility Planning. So I lead on mental health strategy. I lead on primary care model of care and the Center of Excellence model of care as well. So that's my core business at the moment. I'll be more than happy to walk you through the mental health strategies today. I think Dr. Nahida have already touched upon lots of parts of it, but let's start. So the development of mental health strategy started in 2017. I think Dr. Nahida already spoke about the Capacity Master Plan. DOH owns a tool, it's called Capacity Master Plan. The reason why we came up with this tool is we did not know what services we have in the market, how much we have of each services, how much is oversupplied, how much is undersupplied. So we came up with a tool that measures the amount of health services available for the population. And then we model these services based on the need of the population, based on the OECD data. From this, we come up with a demand that tells us the total amount of health services required for the population, and then finally the gap of each services in every discipline. So the Capacity Master Plan tells us about the bed numbers we need in inpatient and the consultation room for the outpatient. We noticed that mental health is a big gap, whether it's an inpatient or outpatient services. And it started in 2017 when we established the model of care of mental health. Then we defined mental health as specialized acute or care provided in a clinical or non-clinical setting to prevent and treat mental illnesses and associated disorders. The model of care approach was to define the baseline, where are we today, and then to benchmark what we have with the best practices internationally, and of course, come up with the gap analysis. So the baseline, we assess the data we have. So as I mentioned, we went to the capacity master plan, saw the gaps we have. We assessed the claims data from health system financing, licensing data as well, and interviewed more than 30 stakeholders from different sectors. So what we found from the baseline, number one, was limited effective awareness and prevention. So the population did not know anything about mental health, or they are even aware, or there were no preventative measures happening in the sector. The other thing we show that the pyramid you see here is upside down. So most of the activities is happening at the specialized care, and less activities happening at primary care. So this is something we needed to address. The third thing we noticed that there is a limited effective cost treatment support and reintegration. So the relapse rate probably was high, and there was no follow-up of the patients who leave the system after getting treated. So that's in summary the baseline outcomes. The benchmark, we looked at international countries. Norway, as Dr. Nahida mentioned, is the happiest country. Canada, and of course in the region KSA, who are putting lots of effort to address mental health issues. And Bahrain have the highest mental health capacity in the region. We tailored what we need for Abu Dhabi. We did not follow anybody's model, so we had come up with a model of care for the Emirate of Abu Dhabi, and you will see what I'm talking about in the next slides. In terms of the gap analysis, and you've seen this slide already, those 10 areas are the prioritized areas for us to work on and close through the mental health strategy. The first one is underdiagnosis of mental health disorder, shortage of facilities and workforce capacity. I think we touched on that also. Suboptimal mental health quality of care. We really need to standardize quality of care for all care providers. Limited primary care role in model of care, and this is really was our focus in the last 1 or 2 years. Limited availability of mental health data. We're working on registry now also, which we'll touch on later. Lack of awareness of mental health issues, limited availability of public information, limited services to support community reintegration where the social work come in place, limited collaboration between stakeholders. This is where I will also touch on. And finally, the lack of dedicated mental health support in schools and universities. So this is the vision of the mental health model of care or strategy to ensure every resident in Abu Dhabi has access to mental health prevention and treatment without social, financial, structural constraints. The strategy have 3 main strategic objectives. Staying healthy, this is where we want to destigmatize our population by educating them, awareness and prevention. The third strategic objective is getting them better by enabling the healthcare system, whether it's an infrastructure, whether it's the standards, whether it's the quality of the services and so on. And I'll come into the details of this. And then the third strategic objective is sustaining health, and that's the reintegration in the social part after getting treated and how we follow up with the patients. What happened after 2017, 2019, COVID happened. So the government realized that there are lots of complaints, lots of mental health problems. We established the helpline. There was a lot of big uptake on that helpline, and lots of suicide, that's what's happening. So this triggered the government to ask DOH to convert the model of care to strategy. In 2021, 2022, 2021, the model of care became a strategy, and this is where we had to bring all our stakeholders in place. It was multi-sectorial approach rather than just the Department of Health doing the model of care. We got on board the Department of Community, the Department of Education, Abu Dhabi Public Health Center, and ECA, which is Abu Dhabi Early Childhood Authority, and Family Care Authority. To elaborate more on staying healthy strategic objective, as Dr. also Nahida already touched on upon, here we're trying to have preventative programs, targeted audience for schools, for universities, for social settings, and early detection of those problems in the primary healthcare settings. So the screening is part of this as well. And under the Getting Better, this is where we want to make sure that the delivery of care is enabled by integrating the workforce in mental health model of care. The infrastructure and capacity should be met, whether it's a bed, short bed, inpatient bed capacity or outpatient consultation room. The quality of care, of course, we had the standards in place and the strategic and operational KPIs. The treatment and access of coverage, this is an ongoing effort. I think we are coming into conclusion on this. Lots of back and forth. We did a socioeconomic impact analysis to make sure that the government supports our outcome of that study and, trying to give the access to entire population for mental health services. Regarding the workforce, we know that we don't have enough professionals and we need to upskill the existing ones, whether they are in the mental health or primary care settings. So this is our initiatives under the Getting Better. Sustaining health is integrating the patients from the healthcare system into the social care, either by group therapy or halfway houses and so on. And this initiative is under the DCD. There are also cross-cutting initiatives with all the government entities, policy and integration. So we are working on the policy and policy changes, whatever required, based on the new strategy. Governance, so governance structure is put in place to ensure that all stakeholders are knowing their responsibility and their roles in this mental health strategy, and they respond to us. Referral case management, of course, we need to unify and unify the services and standardize it. Research and innovation, this is an ongoing effort through our research and innovation team in Department of Health, ensuring enabling new startups for mental health services in terms of diagnostic tools or screening tools or even treatment tools. All these efforts has been aligned with the federal laws, and all the federal efforts is also aligned with our mental health strategy. The guiding principles for the strategy were around 7. So the patient, if you see on the right-hand side, the patient is in the middle. We want to serve the patient by a collaborative approach, more a multidisciplinary approach, starting from primary care, secondary care, and tertiary care, and sending them back into the population, into the community, sorry. So this is more, an integrated approach rather than just being seen in one place and we forget about them. The quality-driven services is put in place. So we have identified KPIs in Jauda, and all providers will be monitored based on that. Value-driven, so we don't want, Dr. Nahida already also mentioned that if we don't do something today, we will be paying more later. So to avoid incremental cost and try to cover everyone now and try to see them, instead of seeing them in more expensive setting like of specialized care, we see them in less expensive setting, which is the primary care. The services has to be accessible, and this is where we are heading to trying to cover all the population, and we will hear something soon, inshallah. Forward-looking and innovative, this is where we are enabling new startups for mental health services. The expected impact of implementing the mental health strategy is, number one, to make sure that everyone in the community is aware of the mental health services. We make sure that there is a destigmatization. We offer preventative approaches to everyone. That's number one. Number two is to flip the pyramid you've seen earlier, to see more patients at the primary care settings, introduce mental health specialists at the primary care settings as well. At the community specialized care, we want to enable collaborative efforts between the GPs and specialists, and see less patients at the specialized care, as needed, of course. And the last thing, we would like to introduce post-treatment services, such as a group therapy and social activities and so on, to make sure that the patients, after they've been discharged, they are followed up on and make sure there is no relapses happening. The target mental health strategy outcomes, we group them into 4 groups. So access. Under access, we have higher share of diagnosed patients. So we want to see more patients diagnosed from 35% to 55% through effective destigmatization and awareness programs. We would like to see increased share of patients being treated at primary care. So at the moment, we have 99% only diagnosed in primary care. We want to increase that to 40%. Well-rounded reintegration support, so include right mix of healthcare services and social support. When it comes to socioeconomy, we want to see increased standard of living of the individuals and increased performance of students at school, making them more absorbent to mental health issues and knowing where to go to and seek help. When it comes to quality, we need to standardize the diagnosis and treatment of all patients, reduce relapses, improve care delivery through comprehensive quality KPIs. Regarding cost, as I mentioned, socioeconomic analysis demonstrated that for every dirham we spent, we will make a minimum of 1.4 dirham saving. So this is our selling point to the government to cover mental health services for everyone in the Emirate of Abu Dhabi. The timeline and achievements so far, we said that we launched mental health strategy in 2019. We activated the task force, engaged mental health stakeholders, conducted mental health workforce supply and demand analysis. COVID hit. We kept the mental health helpline, which was a big hit during COVID. We published the telemedicine standard. In 2020, we published family medicine scope of practice to include mental health services. We published primary care standards, published mental health Jawda KPIs and pilot of mental health upskilling for 10% of the primary care professionals workforce. Please ignore the first sentence. We completed the socio-economic impact analysis to expand and reform the access. What we are looking to complete in 2023 is to activate mental health governance model, which already is being established, to roll out mental health upskilling for primary care workforce, optimize mental health workforce, and publish mental health standards and guidelines, which will be out very, very soon, within the next few weeks, I would say. The highlights and achievements to date. So this is multi-sectorial highlights, achievements. It's not only Department of Health. So far, we increased the awareness of available services. We launched a short survey to understand people's level of knowledge on services that are available. We launched educational workshops, mental health helpline. Development of mental health registry is ongoing, and the full socioeconomic impact assessment to make the case for mental health services for all. So this is our achievement in terms of what we're doing about the underdiagnosis of mental health disorders. When it comes to shortage of mental health care facilities and workforce capacity, we increased the number of primary care providers to 120 licensed primary care providers. There is an amendment done to the PQR for healthcare professional licensing for mental health professionals. And there's still more efforts happening in this regard, the PQR. Regarding suboptimal mental health quality of care, so we published 12 mental health Jawda KPIs, developed mental health guidelines in primary care. We developed specialized mental health standards and published telemedicine standards. Regarding the limited primary care role in mental health model of care, we increased the number of primary care, as I said, to 190, published primary care standard, published family medicine scope of practice to include mental health role and responsibilities. We ran a series of 7 workshops with family physicians covering mild to moderate conditions, and we ran a series of 8 workshops with primary care nurses covering mild to moderate conditions, as Dr. Nahida already touched upon this. Regarding limited infrastructure and services to support reintegration post-treatment, There was a launch of SUD strategy, which is owned by DCD, Department of Community. SUD committee is been put in place. They set up a halfway houses, developed framework related to juvenile delinquents and ex-offenders, trained 450 people for gatekeeper training, suicide prevention, and establishment of IWA for victims of abuse. This is all cross-sector governmental initiatives, not just the OH. Regarding limited collaboration between key stakeholders, we activated the governance model with key stakeholders, established mental health task force, led by Dr. Nahida, of course, consulted with providers, payers, and employers. We ran a Shark Tank event with 6 cutting-edge startups. It's enabled by plug and play. Piloted a startup application amongst DOH employees. Thank you.
Thank you very much, Dr. Modi, for that explicit explanation of our strategy. For our next speaker, I have the privilege of introducing Her Excellency Asma Al-Azri, who is the Executive Director of Family Cases Sector, Family Care Authority, FCA in Abu Dhabi. Her Excellency Asma will be speaking on social sector strategy and FCA's initiatives in relation to psychological well-being. Please welcome Her Excellency Asma Al-Azri.
Assalamu alaikum, everybody, and good afternoon. I would first like to thank all the organizers, DOH team, for giving us this opportunity to be here with you guys to tell you more about FCA's contribution to the mental health strategy. Let me tell you a very brief summary about Family Care Authority. Family Care Authority was established back in 2021, so it's a pretty new organization or entity in the Emirate of Abu Dhabi that is formed through a merger of 3 entities. There was a gap of having a unified family file in the Emirate of Abu Dhabi. So the leadership thought of having one entity, merging Dar Zayed for family care, social service centers that were part of Abu Dhabi Police, but doing social work, and then the social aspect of the Miners Association. So those 3 were merged, and an FCA authority was established. Our strategic positioning points can be summarized in 4 main points. One is to focus on the family as a whole, in addition into serving the individual members within every family, yet ensuring that the required quality of service is provided, addressing the family well-being issues. Second is we want to become, or we are actually becoming, the first point of contact for all families through the establishment of a unified file and direct provision of services along with the integrated case management in coordination with our partners. Dr. Nahida kept emphasizing on the collaboration and integration and partnerships that we are having in the Emirate of Abu Dhabi to serve the well-being of our community. Next is we want to be a source of the data collection in the social sector, and that will help us enhance research, knowledge sharing, and suggesting policy reforms across all related sectors. And last but not least, being very proactive in protecting and preventing family-centric services while ensuring that confidentiality and privacy of our beneficiaries is well maintained. What do we do? And the main role of FCA today, one is to have a unified integrated case management. Family Care Authority is the one of its kind in terms of having the integrated case management for the entire community segment members. In other countries, you would see an entity for the child welfare, elderly, PODs. FCA does it for 8 different community segmentations, including men, which is the first entity that has men as a standalone social segment. So we do youth, we do children, we do women, we do families, people of determination, people who are with troubled past, and we'll come into that for examples, and also elder citizens. We serve them through a set of services, and I'll briefly take you through those services. One is the inclusion programs. Emergency support, Family Care Authority chairs the Social Emergency Committee across the social sector, wherein we receive the emergency cases and we act upon very quickly. We provide counseling, different sorts of counseling, social, psychological, legal counseling, temporary sheltering for those who do need shelter, but they are not abused, because we have IWA for the abused shelter service, foster family support, and we're very eager, we're very proud to say that we have 0 children under our care, or our children are fostered in the community through fostering families, caregiver programs and support for the fostering families and other caregivers in the community, even the caregivers of elderly people, we provide them with the support, training and counseling they need, and then the guardian oversight. Throughout all those services, we collect, we analyze data, and we come up with insights that will help us plan and project for our future, for us to be able to propose and suggest the relevant policies for the policymakers. This is how our strategic plan looks like in brief. Our vision is to have stable and resilient families, and that is to provide a comprehensive services to families and its individuals and manage their cases in a collaboration with strategic partners. And we keep emphasizing that we collaborate with partners. We don't provide all services through ourselves. We leverage on private, government, and also NGOs, service providers. We stand on 4 main pillars: protection, respect, justice, and collaboration. And we have 3 main pillars of our strategic plan. One is to have an advanced and unified case management, which is deploying the integrated case management model and system. We create value from data analytics. Accessible family-centric services, wherein we deliver and sustain family-centric services and adopt effective, accessible service delivery model. And then we will evolve and preventive family care model. We contribute into growing maturity of family care. We deliver integration and prevention programs through multiple enablement tools. One is to have a strategic human capital development, and here comes the capacity building strategy and program. We do have experts and specialized people from different backgrounds, and for us to maintain the high quality of service, we need to make sure that we do have a very firm and clear human capital development strategy, institutional maturity, financial and procurement management, data enablement and data maturity. This is our journey. Today, we are asked to deliver quick wins, to activate FCA, to create the one-stop shop, to activate the integrated case management, to provide individualized services. It's unlike other service providers. Every case comes to us, requires a tailored intervention plan, and that tailored intervention plan tackles the individual, the family that individual comes from, and it could be also for the extended family, and this is the contextualization of the integrated case management that suits Abu Dhabi's culture. Then will be growing impact, wherein we expand the coverage, we prioritize centrality, we maximize integrated case management's full potential, maximizing the strategic partnerships, not only locally but also globally, learning and getting the experts and models and the services and the programs that are implemented and scientifically proved impact and positive impact in the community, for us to become the role model, not only in the region but also globally. Regional Family Care Knowledge Center, maximizing preventive care and efficiently drive the highest impact. So we will be contributing to the development of and enhancing of family care human capital, leveraging on the partnerships and utilizing digital maturity. We won't be able to work without AI, for instance. Halfway house. Halfway house, and this is continuation of what have been said earlier today in the mental health strategy by Her Highness Dr. Mudi. Family Care Authority is the co-chair of the SUD committee that is chaired by Department of Community Development. What we do there in the committee, we are the operational arm of that committee, wherein our case managers and psychologists, we do the initial assessment, the family assessment, the psychosocial assessment of all cases. Once that is done, and I would like to tell everybody that before June, we will open the first halfway house for SUDs in the Emirate of Abu Dhabi. It's an intermediary step-down institution between prison, rehab centers, hospitals, for us to make sure that those people are positively reintegrated in their families first, in their community, and are employed and activated economically. The purpose is to ensure that we have a monitored environment for those people. This was a gap, and it's a gap globally. Relapse is more than 70%. Our aim is to reduce the relapse, making sure that we do have healthy community and healthy youth members in Abu Dhabi. Disciplined environment with rules and regulation will have enhanced vocational and social skills. That house will also provide them with support and counseling. The benefits is to reduce relapse, interaction, hospitalization rates, improve the accountability and responsibility, the family function, and the social support. The model we are bringing into Abu Dhabi is not the classical halfway house model. It's not an assisted house only, but it's a therapeutic rehabilitation center at the same time, wherein whoever graduates from our program will be easily, smoothly re-injected in the family, because from day one, we will engage the family with us in the intervention and treatment plan. The segments is the people with conflict in law. We're finalizing feasibility studies on 2 more elements for halfway houses. SUD will be implemented and inaugurated very soon in a couple of weeks, but we're also looking at people in conflict with law or ex-offenders and mental health patients. Today, we don't have a halfway house for mental health patients, and that is a gap that we are facing in the government. We have targeted group 12 plus for both genders and all nationalities. Another initiative that we will be launching very soon as well, just before June, is our omni-channel. Omni-channel is going to be the platform, multiple pathways for people to reach into FCA's services. That will be the social media, hotline, helpline, phone calls, and also direct walk-in. We cover the entire Emirate of Abu Dhabi. So from Abu Dhabi City to Al Ain to Al Dhafra region, we cover everybody, not only nationals. So we do also serve non-nationals who are residents or even visitors of Abu Dhabi Emirate. The omni-channel will save time by directing users to the right place, so the case or the person will not be lost roaming around different service providers. They will come to FCA, and FCA will direct the person into the service provider. And not only that, the case manager will be following up with the service provider to make sure that the case got the service that they require or they are eligible for. That will bring us into a better coordination and linkage, improved access to information, drives traffic to other service providers. It will easily maintain a better database for us to know where do we have most of the certain challenges. That will help us also to monitor and oversight, improve our inclusion, and reduce duplication of services provided. The integrated case management, and this is my bread and butter, since I'm chairing the family cases sector within FCA. It's an end-to-end organized process, and it's a model that is very unique of its kind, wherein we start with the intake, and then we end up with a closure of a case. Between that process, a case goes through into 6 different steps. Every step ensures that the details, the assessment, the home visitation, all the social workers and case managers' protocols are kept, maintained in a highest level of confidentiality and quality also. The concept of having an integrated case management within a social sector was new to the Emirate. I know this is available and practiced in the medical field, but never in the social field in the Emirate. And this is what we have already rolled out, implemented. Very soon and I have to say this, that we have started deploying this in all centers while waiting for the technological system to be ready, and this will be ready by end of year. So once we have the information system ready, that will integrate us with all even physicians. So it's going to be easier for Dr. Nahida to refer a case to me from her clinic, and then we take it from there to support the family members, not only the patient. So this will ensure adequate life to everyone in this community. I'll take you quickly. This is my last slide. I know I've taken a lot of your time. The other FCA initiatives, what we are doing, we're doing the forecast supply and demand study to ensure that effective resources are allocated and the value is created. For us to project our intervention and outreach programs for the community, we need to know how much of demand is out there waiting for us, and so we can plan our supply strategy. Develop evidence-based analysis to recommend changes, policy reforms and policy changes to the regulators. Activate proactive and interactive engagement plan with communities to understand the root causes of family challenges. Co-design, and this is very important to us, and implement initiatives targeting mindset change or behavioral change programs. Launch innovative prevention programs for youth, and this is a very critical segment wherein that needs our attention, and then we establish programs targeted towards changing behaviors of perpetrators. This will help us ensure that they are healthily reintegrated in the community and in their families. Thank you very much for your patience. Hopefully I've given you enough information.
Thank you, Her Excellency Asma, for the beautiful presentation. May I also call upon Her Highness Dr. Modi to come join us on the stage? We can take some questions. I just want to emphasize, while the question is being asked, that these projects, as you can see, have been not copy-pasted or not learned from any other model. We have tailored and customized it to very much suit our community and our people. Also like to welcome Dr. Dana. Dr. Dana is ex-SEHA, but now she's with FCA and a tremendously instrumental person in implementing these strategies under FCA. Your question, please.
مساء الخير.
مساء النور.
نجم فلاحي من لندن. بالأصل من العراق. Thank you very much for the ambitious strategy of mental health, really. Impressive. I want to touch upon one point, research and innovation, which is extremely important. Our experience from my clinic in London is that we started using the wellness resorts for treating our patients. And I know that a wellness resort will open in Abu Dhabi soon, next year, Shah, I think. The one is in Alicante. The question is that, have you any plans to use this resort? Because we found it very useful in our work. There, we are using Shiva Som, we used Shah. There is an alternative for the patient to go. Instead of going to a psychiatric hospital, they go to wellness resort, and the whole family can go there. And we started educating the wellness specialists in order to know more about psychology and psychiatry. So we are developing a full treatment plan of care for them, similar to our London clinic. That is just a question.
Thank you very much for the question, and very interesting. We've had this conversation several times. I'll let our speakers take the question for now before I give my input. Dr. Modi, you have?
I think Department of Health is already looking into wellness, and I think we are trying to integrate wellness strategy into primary care. But this is something we're still working on it. It's not new to us. I mean, this will be a new approach to all patients, not just address their wait until they become sick, but have a more preventative or more like, you know, the approach of wellness is to try to make sure that people is healthy before even getting into the healthcare system. And that is something we are working on for sure. So I don't know if I'm answering your question or...
Do you have anything to add from FCA? The mic.
It's a series of programs and initiatives. One of them is enhancing the well-being of all the citizens and patients. So that by itself is a whole initiative wherein we maintain a high level of well-being of our citizens in collaboration with our partners.
The concept of resorts is not new to us. Quite a few proposals have been reviewed over the last couple of years. Quite a few of them are coming as commercial engagements. While this is not a priority of the strategy, we are welcoming such initiatives. But also the aspect of social prescribing has been discussed several times with different sectors. So in terms of, as we mentioned, preventative or also even social reintegration, there's a lot of social prescribing that can be utilized to keep that functional recovery and also to maintain wellnesses. So definitely on the radar, but not on the strategy yet.
I am Dr. Prasad Rao from Hyderabad. I would very confidently congratulate you for the ambitious project you have taken. I have one or two questions. I think across the UAE, you have a quite different population. And the healthcare system, which is trying to integrate the mental health care system. Are you using the social media in any sense, or a digital media, like using a WhatsApp messages or smartphones technology to reach out, one, both in early diagnosis and the management, and second, to see the drug complaints?
Thank you.
Doctor, this is better taken by Dr. Nahida. It's more. I think you have different languages, Doctora.
Yeah. So, like you saw in one of the slides, we have different stakeholders, and each stakeholder has their own social media handles, and they have done robust work in terms of providing awareness and education campaigns. We also do collect, as you mentioned, you know, concerns, and like the omni-channel would be one component of that, you know, the platform where people can come by. We don't have an integrated one line or one size fits all type of approach. Each sector has adapted their own. For example, schools have their own way of integrating these social media into this. And Another thing that came up thanks to COVID is social media platforms were heavily utilized for these, for anything that we were trying to translate, and also apps, digital apps, and app-based therapy or app-based information. So, as Dr. Modi mentioned in her slides, we've had Shark Tank events where we have asked young entrepreneurs to pitch their programs or their startups to see which would be most conducive and the most pragmatic way of utilizing digitalization. So again, things are evolving.
Yeah. I have two questions. One is really like out of curiosity. So it seems that I understand that the healthcare system is structured is by emirate, individual emirate. So for instance, now Abu Dhabi being a powerhouse, what about smaller emirates like Al Quwain or so? How does it, is there also a national program so that some of the things you have developed are also provided at a UAE-wide level, or is everything just state-based? And the second question is, I mean, you've done this amazing job of basically, promoting psychiatry at each and every level. How is it accepted? How do people receive it? Are there like maybe town hall events where you actually then showcase what you have and just present it? What is what do people think about it? Are they, when you try to, you have surveys, and so I'm curious, are there some events that you offer, and are people going?
Thank you for the question. Any takers from the speakers?
Regarding the Abu Dhabi, of course, Abu Dhabi is run by Department of Health, so we have mental health strategy for Abu Dhabi. I think the Dubai Authority is also working on mental health, and we did have an alignment meeting with them to make sure that whatever we're doing, we learn from them and they learn from us. The same effort has happened between us and Ministry of Health, which cover the rest of the Emirates. So that alignment has been there already. We also have to follow the federal laws, and I think Dr. Nahida can elaborate more about this. So whatever is happening at the federal level has to be cascaded down to Dubai, Abu Dhabi, and the rest of the Emirates. So in terms of alignment, I think things are ensured that it's there.
The national level strategy is quite identical to the strategy we've shown and shared with you. It's just that the initiative, the speed and the pace at which we are implementing is different. Of course, we have different extra precious resources like the FCA, EWA, and ECA, etc., that add a lot of value to what we are doing here. To answer you in summary, that we do have a national level strategy which prioritizes mental health, but Abu Dhabi has taken the lead on it. There was another question. Yeah. Right. So I think COVID came with a silver lining, and I say this always, that mental health got the boost that it was for long deserving, especially in a community like us. Everybody were backburning mental health. It was like you have to be crazy enough to go see a psychiatrist. But during COVID, we promoted a lot of activities, not just focusing on community of one sector of the community, but we had programs for teachers. We had program for the blue-collar workers, the zone corps. 1,500 people on one of the talks that I was giving in the native language. It was amazing. The questions that followed after the talk lasted longer than the talk itself. So that goes to show even the blue-collar workers or the day-to-day, janitors and the sweepers and cleaners that we see, they had mental health concerns and questions that they raised. So we did start off really well during COVID. We can build on it. We've not done town hall meetings, but we've definitely done, we've had gatherings and mosques and, places of worship with really good response. People are always curious. And as Dr. mentioned, we're not focusing it as mental illness. We're not going and saying we're here to talk about mental health. We're talking about well-being. And this is a concept people tend to pay attention to. We're talking about how we can be preventive, how we can take care of yourself. There is a huge section of the community that is burning out caring for people with disabilities. We are providing support to them through FCA, like it was mentioned earlier. There is a lot of activity happening around providing care to every section of the population, not just limited to the patient with the illness.
I mean, I would like to add to Dr. Nahida that so far all the efforts has been a bit silent. So we're planning to have a big bang launch of the mental health strategy, showing the population what happened and where we are today and what we are aiming for. Having said that, also one of the strategic KPIs is to monitor the uptake of patients in the primary healthcare setting for mental health services. So that will be monitored, and we have enablers. So we need to make sure that the media is supportive. We're talking openly about it. Awareness sessions is happening, enabled by both the public health. So that is our monitoring on the uptake and the number that we want to see that is increasing.
Okay, there's one last question there, if you don't mind. Last.
Hello, Charlotte Kamel from.
أهلا دكتور.
Thank you very much. Thank you very much for all your presentations, and it was very enlightening, the strategic health planning for UAE. I want to check with you something, and the president of the WHO, in his report in 2022, declared that mental health should be a global priority. And following all the reports of WPA as well, we see that. So we need to tackle the basic point that we discover the psychiatric problem or mental illness that people are suffering from. So I saw in one of the reports of the WPA and WHO that in 2030 they want to apply, I wouldn't like to say compulsory, but screening, comprehensive screening to any individual attending a primary healthcare center, a medical clinic, surgical clinic, to discover. Because it was reported that 30 to 40% of population in any country have anxiety and depression. Untreated, they present with somatic symptoms, they present with physical symptoms. So if the doctor doesn't ask about it or assess, and always primary healthcare centers are under severe pressure because it's a 7-minute or 10-minute consultation, and psychiatric history takes a long time. So would you agree with that? I mean, what's your opinion about this, to do, a mandatory screening? I mean, for anxiety and depression, it will be essential because it's, undetected. They come in late stages of depression when, they lost their jobs or family divorce happened or so. But for schizophrenia and other problems, they come early because it cannot be tolerated. So what's your opinion about this?
I would request Dr. Dana to take this question because she's not just a FCA member, but also a family physician, and she's done a lot of primary care integration. And to answer your question, do we agree with it? I think we're leading it. We have already comprehensive screening program that takes screening into account, and she can shed more light onto what kind of screening we do.
Yeah, so I think I'm on the mic. Yeah. Okay. So yes, to reiterate that we do totally agree with this strategy. In fact, it has been taken forward, and we have already implemented the screening in the primary health cares, and we're also trying to screen people who come through the social sector channels as well. So in line with that, because most people who are challenged through their lives might have some underlying mental health issues or further challenges in their life that can be unfolded through the questionnaires. These questionnaires are very easy to be deployed, and patients and even community are now very well aware of them, of their availability. And as previously mentioned by my colleagues here, that they actually started asking, what do you mean by depression? What do you mean by and so and so? So it is a form of increasing the awareness as well. So from both sectors, whether it's health side or social side, it is being aligned with both strategies.
Is it being mandatory? I mean, maybe some people will refuse. I mean, an individual who is not suffering from anything, maybe he will reject.
So it's currently offered, and it is up to the person to agree or disagree. However, non-intake is actually a flag. So this would flag the next step. So usually it is a patient who's coming to primary care, for instance, and the primary care provider will be informed that this patient is not accepting, or whether it's social sector, and again, it's a case that is not accepting, and hence it will be acted upon as possible positive. Exactly.
Thank you very much for the question. Soon we'll be publishing our mental health guidelines for primary care, and there you would see it will be publicly available. We have recognized a few diseases which will be routinely screened for in the primary care sector. Unfortunately, we can't take more questions because of the shortage of time, but thank you so much for being such an engaging audience, and you can reach out to the speakers again after the talk. Thank you.
Thank you. Please, come on.
If I may
Please.
request the speakers to
Please,
stay back
speakers,
for...
please stay. Yes. For Her Highness. Thank you. Her Highness Asma Al-Azri. And Dr. Dan Al-Masloui. Thank you. Thank you. You do wonderful. God bless you. Thank you. And now we will move forward to the next session. And it's my pleasure and honor to introduce the next chairperson, Dr. Hadir Abdulrahman, consultant psychiatrist at the Behavioral Science Pavilion at Khalifa Medical City. I know this young lady for many years. She is highly motivated and she is a wonderful psychiatrist. Floor of yours.
Thank you so much, Dr. Mufid, and thank you, Dr. Midhat, for giving me the chance to be here. I would like to take you through the next part of the day, and it's a pleasure to introduce Dr. Vino Gopal Janwar. Dr. Vino is a senior consultant psychiatrist and the director of the Deva Institute of Health and Care Research in India. He is also working on many projects, voluntary services, which are extremely impressive, and it's a very long list. He is currently leading projects on learning disorders, ERP, cognition of first episode psychosis, empathy, cognition and virtual reality, in addition to conducting regular workshops on reducing and identifying caregiver burdens. He's a member and officer of many of the professional medical associations in India, including the Association of Bipolar Disorder, India Association for Biological Psychiatry, the India Association of Private Psychiatry, Deva Foundation, and the Mission for Mankind. Please help me welcoming Dr. Vinu, who will be taking us through a SWOT analysis of running a psychiatric rehabilitation center in rural India. Thank you.
Hariom. Thank you very much for this opportunity. Actually, this particular presentation was, initially we thought of it, doing it as a symposium, and it was actually planned like that. So we are basically 4 speakers taking all the 4 parts: strength, weakness, opportunity, and threats. But we later understood that the time span is just 25 minutes. So we all will be very fast, and there will be other 2 speakers along with me who will be doing this presentation. How do I move the screen forward? This way? Can I go to the first slide, please? Is there any way? Can anybody help me? Tell me the next. This is so we all know that the way India is developing and way it is growing, psychosocial rehabilitation facilities in India have improved tremendously over last 1 decade. But for all said and done, it still needs to go a very long way. And it is here because of the numbers which we have, and overall the population of people suffering with mental illness is about 10 to 14% in different studies and different data. There's a huge strength here which lies for developing a psychosocial rehabilitation, particularly in rural India, because it's still rural, semi-urban and urban. Rural and semi-urban would comprise about 65% of India's population, which is a very large number, which I'll be taking you through the slides. So with this, I'll first call Dr. Rajesh Nagpal, who will be taking through the weaknesses of the development of the center. Dr. Rajesh.
Good evening. I am Rajesh Nagpal, psychiatrist based in Delhi. So, there are 2 aspects to the problem we are facing. In India, vast majority of our population, our population today, the world's most populous, beyond China too, do not have access to any meaningful psychosocial intervention. A full function, integrated rehabilitation service is a distant dream. We do not have any rehabilitation service running in the rural sector by the public health system throughout the country. So we have no replicable models of those sorts. Since there are no replicable models, organized rehab services with adequate budgeting and human resources are scarce in the government and NGO sectors, 2 primary sectors dealing with psychosocial rehabilitation. Government initiatives are stuck in red tape, bureaucratic wrangling on norms, SOPs and linkages are not yet available in the field. Replicable initiatives are very few. For example, a place in Bihar called Kolwar, near the Shan River, has a 240-acre campus devoted to psychosocial rehabilitation. 1/3 of the campus is occupied by the paramilitary forces. 2/3 of this is left with beds, empty beds, and outpatient services available twice a week from the capital of Bihar called Patna. That's the status situation in our country as of today, in Bihar. One of the elephants in the room, which we don't talk about, are halfway homes, supported accommodation, and community services, which can be the backbone today of psychosocial rehabilitation service in the country, are not subject to debate and discussion. Halfway homes are conceptualized inside the mental hospitals, today rechristened as institutes of excellence, and not outside the mental asylums. They, of course, merit a short note during the PG examination of our young children who will undertake examinations. Psychopharmacological management of treatment-resistant schizophrenias is the evergreen flavor throughout the Indian subcontinent when we discuss about psychiatry. Emphasis is primarily only on acute care and outpatient care. One segment of need for patients, the psychosocial rehabilitation, the concept of societal problems leading to SMIs and CMDs is completely sidelined. There is, about 5 minutes ago, we were talking about this issue outside the hall. There is a clear conflict in treatment approaches which sharpen during rehabilitation. Biological and psychosocial treatments, which we are trained in, focus on deficits at the individual level, symptoms and disabilities, and we are familiar with the ICD and the DSM and thereof. Social interventions, trying to address local inequalities and barriers in order to improve access to service users, to ordinary housing, employment and fun opportunities, are not discussed in any forum, except for few like these. The history of mental health in India tells us that social care is often underfunded and too easily dismissed as not the business of healthcare. And that is why even our education system is such, primarily focusing on a treatment of acute illnesses. Excessive emphasis on a health model of individual deficits is a slippery slope to isolation by way of therapeutic nihilism. And that's one of the major problems we are going to face. So I also suggest, therefore, an opportunity. I suggest a shift in emphasis. Rehabilitation services now more biological than biopsychosocial. In fact, we have now moved from biopsychosocial to only biological. Need to acknowledge the central role of social interventions. Just as we say that improving cognition improves outcome in rehabilitation services, social interventions improve the functional outcome that matter to patients and caregivers. Theoretically, access to housing, occupation, leisure facilities, and the support of family and friends can enhance functional outcomes. A lot of evidence for this. For a developing country like India, these interventions, without economic heft, even the current allocation for the mental health is still very low, provided by the state, remains a theoretical exercise only. The larger goal. Rehab is framed within a model of personal recovery. Target of intervention is to boost hope and help the individual find a meaning to life, living well regardless of enduring symptoms. But we see here a basic unfairness when you prioritize only individual change by means of drugs, by means of resilience training. The social perspective, cause and maintenance of mental problems lie outside the individual. Example, childhood trauma, or the toxic influence of stigma and discrimination, or bullying in childhood, molestation. It is imperative that external social conditions change. Dealing with external factors involves working with multiple actors with different interests and agendas, and what may be good for alleviating mental health problems may run counter to how a society responds to inequality. You may be aware that the Supreme Court is now seized of the problem of the lesbian, gay, and the transgenders, and the queers and their rights. And there's this complete social kind of a change happening in the Indian context. At the risk of unfairness, more attention and resources given to interventions aimed at changing the individual. All the funding is for individual change, drugs. Even if the obvious defect lies externally in abusive relationships, discrimination, or in structural failings of society. Stigma, for example. The realistic goal, therefore, is the patient be contained within the premises and taught or retaught basic life skills. On discharge, he be manageable at home with some ability to look after his own needs. So my submission is that the weaknesses stem from our approaches towards psychosocial rehabilitation. During our training in psychiatry, in most medical colleges, there is little or no emphasis on psychosocial rehabilitation. The two premier institutes of the country, or three rather, have outpatient services, community services, but no indoor rehabilitation service. So unless we are training people, unless we are making our psychiatrists sensitive to this idea, no progress is now possible or feasible. With that, may I invite Dr. Venugopal Jhavar, please conclude the discussion, and then Dr. Anukan Mittal after that.
Thanks, Rajesh. See, whatever is the weakness, I'll take you through certain numbers, which will be very interesting, those who have interest in this part of the country. And this will also invite a lot of investments in our country, those who want to enter into this area. Imagine we are 1.4 billion, and very conservative average people suffering with mental illness is about, that's about 10%. And severe mental illness is about 14 million, which is a huge number. Rural population is 65 to 75 and urban is 25 to 35. Average 70% of our people reside in either rural or in semi-urban. And almost 80% of all psychiatric facilities are in urban areas. So this is the major divide which leads to, which is the genesis of the opportunities. Almost half of people suffering with SMI need psychiatric rehabilitation facilities. PSI-R will stand for psychiatric rehabilitation facilities. And this number is almost like 7 million. This excludes intellectual disabilities and substance abuse. Of this, 70% is in rural area, which is about 5 million, and the treatment gap amounts to about 90%. And there lies the huge opportunity. Per capita income is increasing significantly. It's like growing leaps and bounds. Out-of-the-pocket expense for health is reduced dramatically because of all the efforts of our good government. Insurance is covering mental health now, which was a dream, but now it is readily acceptable. And the government-sponsored world's biggest healthcare scheme, Ayushman Bharat, is a super hit in India. And that has covered almost all the psychiatric disorders. PSI-R facilities is specific to rural areas. Opportunity is immense as the patient number is huge. There is a need, which is also immense. It should be a very welcome endeavor, as people won't have to travel to urban or city areas. In general, almost in whole country now, basic infra is par excellence. And it's not a difficult facility to develop. It's like, I would say on the scale of 1 to 10, the difficulty would be around just 2 or 3, not more than that. The cost will be 1/3 if we develop the facility in the rural areas. Land is almost like 25 to 50% cheaper. Construction is 20 to 25% less. Salaries will be lesser as compared to urban or the metros. The only problem here would be getting professionals and retaining them. You may get them, but to retain them would be a problem. These are the type of psychosocial rehabilitation which is mandated by our Mental Health Care Act, which we follow now, 2017. Short to mid-term facilities, long-stay facilities, geriatric homes or geriatric services, child and adolescent care, de-addiction center, halfway homes, daycare centers. Briefly, I'll go through one. Short to mid-term facilities, these are the most needed facilities. And these are like prototype of a psychosocial rehabilitation center. Generally, these are the centers who cater for 3 to 6 months, and major work is active rehabilitation. They should be able to cater to the acute care, and they should not be very far from city limit, because in case of an emergency, patient can be rushed to hospital. Required area is not much. What is required most is the professional and the skilled manpower. Long stay facilities, interestingly, the concept itself is confusing. We equate with this old days word of institutional care, but that's not true. This even is very relevant today. Good number of people suffering with SMI or persistent and severe mental illness, they still require long stay facilities. Imagine a chronic schizophrenic person who has no one to take care, or is so difficult that a family cannot take care. What will happen to such person? Where he or she will go? This center can be in rural settings. In fact, it is better to develop there. The areas required is large. We can have large numbers. Major thrust will be still on ADLs and the cognition. These are generally big centers, should be linked with acute setup, community, and halfway home. So it's like almost like a triangle. The geriatric home, these are the need of the hour. The scope of service is huge here, wide. It's very wide. From daycare to long-term care to lifetime care to respite care, they need a very specialized care. Here also the opportunity is big, and interestingly you will be surprised. There are 4 different firms from North America who have now, along with our different state governments, have done an MOU to develop 18 long-term old age centers in India. And 20% of our population exactly is 19.8, 20% population will be above 60. And we all know that how dementia and how much is the prevalence of dementia. Now, this is one area which needs attention and also a lot of debate also. Imagine a family where one child is moderate to severely intellectually impaired, has severe behavioral problems and several behavioral problems, compromised ADLs, and so on. The list is how. What to do with such boys and girls, say age is around 14 or 15. They require almost long-term or lifetime care. Daycare is fine, 9 to 6 p.m., but then after that, parents can't handle them. This particular population in itself is a huge population. And as of now, we do not have centers for that. So there is a huge opportunity in this area. The outcomes, unfortunately, are sad and serious. De-addiction center altogether is separate, a different entity and a different scope of services. Most challenging among all the SIR facilities. Challenges are multiple. Few of them are legal, social, financial, and then many more. The scope has a wide scope of services, from detox to long-term care, requires specialized and trained manpower. Relapsing nature of the illness adds to troubles. That's one of the bigger problems. Other than known substances of abuse which we have been treating and which we have learned in our medical schools, now we have to handle many novel and synthetic drugs, and we do not know most of them. Halfway homes, as my previous speaker, Dr. Nagpal, pointed out, more said than done. They are the most required thing for ultimately going into community and for empowering them. Though it is a legal requirement, ground reality is different. Here, scope is also huge because numbers are really big. Can be built in a very low budget cost, and the most important is does not require specialized or professional manpower. The real opportunity. We need large number of such centers. The present facilities are not even able to cater 10% of the needy population. So 90% of scope is there. If we can manage to control cost, both developmental and operational, SIR facilities of all the types which I discussed are good business proposition. The revenue models will not only vary from place to place, but also from kind of service provided. In next 10 years, India should have minimum 100,000 beds in SIAR facilities. And surprisingly, the budget, the revenue only from SIAR services could cross 1,000 crore figure. Thank you very much. With this, I invite last speaker, Dr. Mittal.
I've been told I've got 4 minutes. Good evening. Thank you for the opportunity. I am going to speak about the threats to the mental health rehabilitation sector. I'll start by speaking about the potential barriers. My previous two speakers have spoken about the opportunities available and the weaknesses. All this is available, so why is not anybody exploiting them? Why are we not having these services? We're not having these services because of barriers and the threats. Despite the potential, there are certain threats. And what are these threats? Regulatory. The Mental Health Care Act of India, 2017, which has mandatory guidelines for mental health establishments in terms of space, structure, as well as the ratio of staff, trained staff at all levels to the number of patients, mandate specific procedures and operating protocols to be followed, the oversight regulatory committees of the government officials, some of them, most of them, who are non-psychiatrists or psychologists, to look after them, the rules governed by the Rehabilitation Council of India, which is a separate body, which mandates qualifications and registration for rehabilitation therapists and rehabilitation personnel, for which there are only 10% courses available as required, and in the next decade, we will require to cover the shortfall at present. Forget the shortfall that will arise with the growing population. Then, of course, we have the one about immigration. I'll come back to that later. Limited financial resources. As, I just go back. Sorry. I'm sorry, I just probably, the input cost, as Dr. Jhamar mentioned, there is the last line he said is the return of investment is 1,000 crores or more. But yes, input costs, first of all, you require the cost of the land. Urban is very, very, very expensive. In fact, some of the cities in India are more expensive than the cities in Europe. The rural as well is not cheap. It is very expensive. The construction costs are very expensive. And of course, you cannot distinguish much between the costs of what you pay trained staff in the urban areas versus the trained staff in rural areas, because urban staff may not require accommodation and travel, while the rural staff will require that. The return of investment is going to take a long time. The cost to the patient is going to be more. Recruiting and retaining qualified staff. There are deficiencies in training institutions, lack of trainers, poor access and availability of centers. There are culture and language barriers. These are the major threats. India is a land of multiple cultures, multiple languages, multiple dialects. And in psychiatry, we know that in rehabilitation, you need the workers to speak the same language in the same dialect as the patient to be able to understand and to do work with them. There is lack of community support. There is stigma. Nobody wants a rehabilitation center or mental health facility in their vicinity, in their village, in their district. In the olden days, even I have worked in a mental hospital which is 20 miles outside the main city because no city wanted them within the sector. Stigma, as somebody mentioned, culture-bound family, these are threats. Nobody wants to put their patient in such rehabilitation centers or long-stay centers, or as we call them as old-age homes. There is indoctrination in them about these being mental illnesses which are not going to be corrective. And the biggest threat, quacks. untrained doctors, untrained personnel, set up facilities at half the cost because they don't come under any regulations of the Mental Health Act or the Rehabilitation Council, and they do not pay so much. They run the center as dumping grounds for patients who are chronically ill and who require chronic care. Thank you. I hope I finished my time.
Thank you so much, doctors. Please welcome Professor Dr. Ganesan Gopalakrishnan, who will be joining us virtually, taking us through the innovations of care and homeless severely mentally ill. He is the CEO and Chief Consultant at Somanasiya Hospital and Institute of Psychiatry in India. He served as a professor and head of department of psychiatry at MVJ Medical College and Research Hospital. He's the past president of the India Association of Social Psychiatry, past president of the World Association of Psychosocial Rehabilitation, member Ethics Committee and Research Advisory Committee, Christ University, and he has special interest in social psychiatry and rehabilitation, research on mental health and delivery systems. Please welcome him.
Good evening, friends. I'm sorry I'm unable to join you in Abu Dhabi, but it's been a wonderful experience hearing some of the lectures since the morning. And I am going to talk to you on one of the experiences that I have had over the years. There is something which is new, something which is old. I'm talking about the innovations in the care of the homeless, severely mentally ill in India at a place called Gunasila, which is about 25 kilometers away from Trichy. It is situated on the river Kaveri basin. Next slide. Next slide, please. Faith and mental health go together as far as India is concerned. You know, most of the people who need psychiatric help, hardly 10 to 15% visit psychiatrists. Most of them go to faith healers or religious places for over time. And in India is probably very similar to the West, but at the same time more specific because facilities were not available and people had to resort to uh, faith healing places which are there all over the country. But I'm going to talk about a place which has been known for looking after the mentally ill for the last about 200 plus years. Next slide, please. India has about 1.77 million homeless people. The NMI survey estimates 1% of the persons are homeless and about 20 to 25% of homeless people compared with others non-homeless have severe mental illness. About 1/3 of the homeless suffer from mental illness. This is the reality. Hardly there is any program to look after all these people, even though some have been proposed. Next, please. The homeless mentally ill and the prevalence is about as the previous speakers have already highlighted the number of things that have said that we have to get it about 1 to 2% of the population as per the United Nations Health Survey, and we have about another 10% of them who would need long-term care, not in our hospitals because we have not increased the number of mental hospitals. It's been 42 from the last 75 years plus. We have not added. We have only had general hospital units, and we have had a district mental health program in place. There are organizations like the World Association for Psychosocial Rehabilitation who have tried to help the families in distress and then made an organization to look for and care for. To mention about Dr. Sarda Menon, who was the past uh, president of this organization in India and one of the founder members of the WPR, went a long way to talk about psychosocial rehabilitation, and then she started the program in the scarf, which I will share you in a minute. And needless to say, faith and healing have a remarkable role to play. And the family role in the care of the mentally ill is something which is much more than most of the countries in the world for two reasons. One is we are the people who give all kinds of care, more so when a person is mentally ill. Next slide. So the family plays a very important role and they have their own limitations in looking after many of the things. The government of India has already planned that, the people with mental illness, homeless especially, are vulnerable to acquire and spread infection. They had problem with housing and food. We need to test them for COVID. We need to give them vaccination, and most of them are on the street. And the large number of people who are on the streets have been phenomenal over years. There is no, as my previous speakers from India, Venu and Anupant, and they have already highlighted a number of shortfalls in terms of what is not there, especially Rajesh has already told you about a number of things that we do not have an organized program from a national perspective. Even though they did talk about the national mental health program, and then they said they will start in Bhopal, a big rehab center, which is still to see the light of the day. This NGOs have played a big role, non-governmental agencies, to care for these people which have been a part of the healthcare system in India. Next slide, please. Next slide, please. There have been very few community-based rehabilitation works in India. To mention the first is about START, which is the Schizophrenia Research Foundation, a non-governmental, non-profit organization founded by a group of philanthropists and mental health professionals led by Dr. Sadam in Chennai, in Tamil Nadu. They have been existing for the last about 3 decades and improved the care and the research for people with, severe mental illness. The outcome studies is very famous. They have followed up patients for 30 plus years in urban and rural areas, which have been published in many journals all over the world. Next slide, please. Next slide. So Richmond Fellowship is in Bangalore. This is also has been providing since 1986. Of course, they have a therapeutic community, and then they have a fountain house model to care for the mentally ill, and they operate on the principles of therapeutic community care. They have a daycare center also in the city, and they have been doing well. But there are shortages. They have also opened in the rest of the country apart from Bangalore. And then they have also been caring for the chronic mentally ill, which also again NGO. Next slide. Another important one is the thing that I would like to tell you. The Erwadi tragedy that happened long ago in Tamil Nadu, where lots of people who were, you can see the charred bodies after they were all killed, after a fire that broke out in the place where most of the inmates were there, in a place called Erwadi in Tamil Nadu. This changed a lot of things for India. Supreme Court came into the picture to look after the mentally ill, and then lots of things, good things have happened. The bad part of it, that the chains were there at the time, and that's why these patients had very bad, tragic death. Next slide. So this also made consequences was the Supreme Court of India immediately directed the government of India to provide reasonable mental health care to all and submit a report within a very short time, and it did happen. And then it made some changes, but not to a very desired level with a large population. Next slide. Next slide, please. Now I'm going to talk about this temple where we have been providing, this temple has been attracting patients for the last about 200 years. We have been running an OPD. We are also running a program for the mentally ill, an outpatient and an inpatient service for rehab for the last about 25 years plus. It's a very, very small temple. It's a private temple devoted to Lord Balaji. And then this catered to a very rural population. And then, but people from all over the district and nearby areas do come. Next slide, please. This is the temple which people do come, and this is how they offer their prayers. Guna means the nature, character attained through following such cultured and civilized lifestyle. Shila means virtue, especially one associated with both the individual and the society as a whole at the same time. Next slide. You are seeing the process of praying the temple. This is the presiding deity of the temple, large number of people who come not with just SMI but also with common mental disorders, and it means attracting funds not just from Tamil Nadu. In fact, most of the movies would just say, if you have a mental illness, please go here. That is the normal thing that happens. Next slide, please. Next slide. So this rehab center is near the temple. This can accommodate about 50 patients. They have facilities for, it's in a 1 acre plot. The plot belongs to the temple, and you have rooms where patients can cook. The family, see, we have earlier provided only with family support, only families who can also stay with them for a period of about 48 days minimum, to offer the prayers at the same time also take care, and we run the center, all the antipsychotic medications, all the programs for normally treating a psychiatric illness is all in place. We run a OPD program on a Monday, a Tuesday and a Friday from 8 to 1. And most of the things are carried out either by the temple trust or by people who keep donating through the temple trust to the center. Next slide. The Gunaseelam rehab experience is fully funded by the temple, which is privately owned. The mental health services are provided by us on a voluntary basis since 2003. Next slide. And we have no conflict of interest. The inpatients stay usually for about 45 days, during which medicine, prayer at the temple are done. Special prayers for patients, occupational therapy, gardening with the help and upkeep of the temple. All the community resources are being utilized for rehab purposes. Of course, my friends, we have been talking about stigma. Stigma is still a very major issue in a country like India. The stigma is to visit a psychiatrist is probably most difficult in India. And then, but people come to the temple, then probably they feel that they are a part of other people who have similar problems, and then they can share the experiences. So psychiatrists on a visiting basis to the temple, and there's a bond between the faith healers and the psychiatrist, so that where patients come, we give the service in that place. Next slide. Next slide, please. The advantages of this model: about 30,000 patients have benefited from this integrated model of faith and mental health care. There has been assessment, diagnosis, medication management, follow-up, and skill development. This model uses community resources only. Stigma is reduced as the center is within the temple premises. Psychiatrists are visiting places. There is a bond between the caregivers, the faith healers, and psychiatrists. Next slide. Now, recently we did start for the homeless mentally ill. Previously, as I was telling you, it was only people with families are admitted. Currently, in partnership with the temple and the district mental health program and Banyan, which is a big non-governmental organization based in Chennai and South India, where I do work, and we provide the care and service for the ECRC project, which is the project of the government of Tamil Nadu to look after and rescue homeless mentally ill and then offer care over a period of time, including the rehab, relapse prevention, and then bringing back to the families. And then I will share you in a few minutes what is the one which is. This we have been running for the last about 2 years. Next slide, please. Next slide, please. This is the standard operating procedure that we do when we have to admit a person who has been rescued. We have a CSR report from the police, and then we look after the medical needs, and then we also have appropriate district mental health program which provides the funding, which provides the drugs sometimes. Sometimes we provide, most of the patients we do provide. We also provide psycho education, and we also refer to the governmental hospitals in case there is an acute emergency, and there's an ambulance which is always stationed nearby. Next slide, please. Now, these are all rehabilitation services. You can see gardening. These are all wonderful gardens. The flowers for the temple are being done in this place. And then people used to take out all the garlands to use the dry powders for making colored powders for the holy, and then also use it for making kolam, which is a very common thing in our Tamil Nadu state. Next slide, please. Now, these are all the things which are the local plants from the trees. They make all these leaves, and then they also, most of them use it as a pen to hold the pens or to keychains. Number of these things. Most of the people who visit the temple buy all this, so that most of them do make some earning out of this. Next slide, please. Next slide, please. Next slide. Yeah. Can you play the video, please? Can you play the video now?
There's a lot of use of symbolic elements like the lemon or a flower. It's a symbolic gesture of an act which people believe will actually provide a kind of a treatment for whatever problems that the individual has. Actually, there's data which suggests that more than 70% of the people actually seek religious treatment, faith healers. They may be going to temples, dargahs, churches, or to a independent faith healer, traditional healer. They may be going there as the first line of management.
Sure. My name is Dr. Arudra Gopalakrishnan. I practice psychiatry in Trichy for the last few years now, 5-6 years. I've been involved with the rehabilitation center because where I'm associated, Saumanasya Hospital and Institute of Psychiatry has been in this field serving the mentally ill for 40 years in Trichy, and we have extended our services free of cost to the Gunaseelam Rehabilitation Center for the last almost 3 decades now. The norm is they will say, the person will start acting very weird. He was talking to himself, so we thought there was a ghost. So we went to this temple. We went to the astrologer. They said time is, the time period right now is not good.
அந்த எம்ஓ பிரகாரம் அவள் வந்து டாக்டர்ஸ், சோஷியல் ஒர்க்கர், நர்ஸ் எல்லாமே அவளுக்கு எங்களுக்கு கொடுக்குறா. ஃப்ரீயாகவே அவள் வந்து சர்வீஸ் பண்ணுறாங்க ஃபுல்லாகவே இந்த சென்டருக்காக. நாங்கள் வெறும் அக்காமடேஷன், ஃபுட்டு அதெல்லாம் மட்டும் அந்த பூஜையில் என்னென்ன பண்ணணுமோ அதெல்லாம் அவளுக்கு நான் பண்ணிகிட்ருக்கோம். அது கிட்டத்தட்ட அது இந்த சென்டர் ஆரம்பித்ததே சவுமனசி ஹாஸ்பிட்டல்லேருந்து தான் ஆரம்பித்தோம். ஏன்னா அது இல்லாமல் பண்ண முடியாதுங்கிறனால அது மாதிரி ஆரம்பித்தோம். அதுக்கு முன்னாடிலாம் வந்து எப்படின்னா இங்கே கோவிலில் தான் இருப்பாள். அவளுக்கு வந்து செயின் போடுவோம். செயின் போட்டு தான், ஏன்னா கண்ட்ரோல் இல்லாமல் இருக்காங்கிற மாதிரி இருக்கிறதுனால அவளுக்கு செயின் பண்ணி தான் பண்ணிட்டு இருந்தோம். அது வந்து கூடாதுன்னு தான் கவர்மெண்ட்டில் பேன் பண்ணிட்டாங்க. அந்த மாதிரி பண்ணக்கூடாது.
So the chains had come off here after we've come into the picture from Saumanasya Hospital, and we've said that psychiatric care would be provided. They would be assessed, and then accordingly they would be triaged into the different modalities of treatment. If they get admitted, then we have what we say one mandala, which is 48 days. They have to stay here and they will get involved in certain activities. Like for example, we would have what we call scheduling for them. Like they have to get up at a particular time, have a bath, then go to the temple, be involved in the prayer and other things.
ஸோ அந்த 48 நாளுக்குள்ளே அவள் வந்து வர்றவா படிப்படியாக நிவர்த்தியாகி அந்த 48 நாள் பூர்த்தியானவொன்னா நல்லபடியாக நிவர்த்தியாகி போயிட்டு.
The 12:30 puja is very important because at that time they actually, the prasad that is offered, like the holy, the water, right? Tirtham, that is actually put on everybody's face. I think, it is a good combination of the basic faith and certain practices that we are able to put together for them.
மனசு பொறுத்தவரை மெடிசன்ஸுங்கிறது ஓரளவுக்கு தான் பண்ண முடியும். மனசு சம்பந்தமான அந்த மன அழுத்தம், அந்த மனத்தில் இருக்கிறத ரிலீஸ் பண்ணுறது அப்படிங்கிறது பீஸ்ஃபுல்லான ஒரு சூழ்நிலை இருந்தால் தான் அவளுக்கு பண்ண முடியும்.
May I ask the speakers please to come up to the stage? I think we virtually lost Dr. Gopala Krishnan. However, we would like to open the floor now for any questions, please. Dr. Afzal, please.
With the Q&A, I'll put you on the...
Well, thank you very much for this, to all the presenters. I think we really got very informative information, especially the work coming from a low and middle income country. I have one question for Vinu, for you. Your model is exceptionally great model. I wonder if we can make a case of its cost effectiveness, because this is the way that we have to really sell these good projects. The government, the non-government, if we tell them that, look, you are investing this much money, but you are saving this much money, and you are gaining this much money. I would suggest you that from your experience, if you could really make a financial case, that would be the best thing to promote this particular idea. Nobody will deny the importance what you are saying. Sure. But when it comes to the practice, we have to show the way that, look, this is the best way. Sure.
Support voluntarily asking people, but we have all the funding has been coming from people voluntarily, and over a period of time, if we have sustained for 25 years, I am sure it is going to sustain forever. Simple reason being that maybe, as you have rightly said, this is a good community model which is good for low-income countries, because it's where people are there. It is better to treat them there rather than taking them to institutions where which they do not want to go.
Any more questions?
Just have a quick question. Thank you so much for your presentation. I was curious to know how effective it would be to use Ayurvedic practices as early intervention for providing any extensive services.
Could you come again?
Ayurvedic practices?
Yes. No, these practices, see, the problem is most of them, if you see, most of them are on antipsychotics. Previously, antipsychotics were never used in a pain-healing place. Now, currently, evaluation is done. We make ICD-10 diagnosis. We take most of them to these centers of chronic mental ill people. With most of them were also on long-acting antipsychotics, and most of them do participate because if you voluntarily, most of them say that we want to go. Excepting currently, as far as the hopeless mentally ill, because these are all people we picked up from the street, we have a problem. We request them, in case they want to, they can go. If they don't want to, they will not. Irrespective of religious practices, many of them come. There are so many Muslims, there are so many Christians who are also coming to these centers for help because they just want to get better, which is on a voluntary side. But as far as the homeless people, most of them are picked up, so we give them a choice. We don't force them to do. But normally these people, what they do, because all other people go, they also get up and attend to their hygiene and then visit the temple and then come back. Voluntary thing. Both go together. It's an effective model, cost effective, because hardly, and we have no governmental support in terms of monetary funding. And we have survived for 2 decades plus.
Thank you so much. Any more questions? Well, I do have a comment to the speakers, actually. I would like to thank you for taking us through a screenshot for what a developing country can do to try to seize the opportunities there and to help these individuals which are using the resources in every way possible. And I would like just to have a comment on the 48 days stay in the hospital, which was mentioned by Dr. Krishnan, how this was dictated by my understanding of a cultural and spiritual background and not dictated by insurance companies, which is the current way that we do now. So thank you so much. I love the integration, and we hope to integrate with every country the different cultural and religious backgrounds and integrate this into psychiatric practice.
Sure.
Thank you so much, doctors.
Thank you for the opportunity.
Yes, please, sorry.
I am Ahmed Al Ansari, psychiatrist from Bahrain. I am impressed with the courage that the team have shown us the real situation of mental health services in India. That's not very easy to do it in public. What I think about in India, that you have to be creative and you find Indian solution. You don't follow any of the Western model, or your cornerstone problem you have is with the trained staff. And unless you solve that problem, you cannot go forward. You're talking about land, and you're talking about buildings, talk about stigma. Leave that apart, but who's going to do the job? And unless you find a solution for that problem, having a trained Indian people living in the same area, I don't think you would go further with your ambitious program. Thank you very much.
Thank
you. Over a period of time, and where we mix together two things, where people go and we try to help them the place they want to be treated.
Okay, now we would like to thank the speakers for their contribution, their valuable contribution during this program. Dr. Vino, thank you very much.
Thank you so much, Dr. Hadir. Thank you for the speakers and for the audience who asked. It's a pleasure to introduce our next chair, Dr. Fatima Al-Mansouri, consultant psychiatrist. She will chair the keynote sessions. Welcome, Dr. Fatima.
Thank you, Dr. Mufid. Thank you, our respected audience. You stayed with us this late. In therapy, we say the opening part and the ending part are the most important parts of the session. So the ending part is the keynote is very important. We will be, our distinguished speakers will be talking about ADHD as well as autism. They will update our knowledge and help us care for our patients. I'm not sure about you. I work in private right now in specialized rehabilitation hospital. And my clinic is called Psychiatry Rehabilitation Clinic to try to decrease the stigma. In my clinic, I see lots of ADHD. Patients come and tell me, I've diagnosed myself, I have ADHD. And I can see there is an increased trend in autism spectrum. And in both situations, I usually scratch my head. I'm not sure about you. I find this challenging. So stay with us to learn more about these subspecialized topics. So the first topic is throughout the lifespan. optimizing treatment of ADHD. Our distinguished speaker is Dr. Bassem Hamid Mohammed Badr. He's a consultant psychiatrist and head of psychiatry department at MediClinic. He's the head of psychiatry department at Dubai Police, DHA Dubai. Medical director at LifeWorks Holistic Counseling Center, DHA Dubai. Without further ado, help me welcome Dr. Bassem to the stage.
Thank you, Dr. Fatima, for a kind introduction. Actually, all of us, we face the same in our practice related to the ADHD. We are either between two pools, either to rush to diagnose under enforcement of the trend of being diagnosed, especially in young people, as ADHD. All of them go to Google and they make a checklist and they find themselves ADHD. And some true ADHD patients, they are not coming to us and they're suffering a lot and they lose a lot from their life and their quality of life and family lifestyle. This is one example of a lot of questionnaires on internet. Everybody go and check himself, and mostly subjectively they find himself doing a lot of symptoms of ADHD, so they diagnose themselves as ADHD. Our objective today, sorry, I'm going in wrong direction. Yeah, sorry. This is the right way. Yeah. Our learning objective today to recognize the clinical presentation, actual clinical presentation, differentiate between ADHD in childhood and ADHD in adult and adolescent patient, to try to identify the efficacy and safety and formulation differences of approved stimulant and non-stimulant treatment option of ADHD, optimize medication selection to promote all-day symptoms management, because this is challengeable also for us when we give stimulant and we face side effect and we can keep the patient all the day manageable. Manage medication treatment plan for patients with ADHD during transition from childhood and adulthood. I will try to cover this during my lectures. The onset of symptoms of ADHD, the onset of symptoms of childhood ADHD, as of all of us know, it is started before 7, but we can diagnose except on 7, at age of 7. Some papers said we can diagnose before, but the guideline, the true guideline, we can diagnose anybody as ADHD before the age of 7. The adult ADHD has to start, according to the guideline, before the age of 12. The symptoms and the misbehavior and suffering, it has to be before the 12, and then it will be continue in adolescence. Now, some research also try to say some people, they come like adult ADHD without history of child ADHD, but it is off-label and it is not evidence-based medicine. Also, there is area from age of 50, thanks God I'm still 30, starting of deterioration of cognitive impairment. One sign of this deterioration, I lost my tie today and came without tie. And I didn't find it in my bag. So at the age of 50, menopause related for women, pseudo-dementia with depression, mild cognitive impairment also there because of atherosclerosis, cardiac disease, chronic illness. Substance abuse also to affect, and dementia by the end of age of 70. All of this affecting our attention. So it is not only of ADHD, so we have to take care according to the age. There is big effort in 1990 from American Academy for Pediatrics to find guideline, American guideline. We know there is British guideline, there is Canadian guideline, there is international guideline for ADHD diagnosis for children and adolescents, but till now there is no American guideline for this subject. ADHD diagnosis approach not routinely recommended, which is a myth. A lot of people consider the neuropsychological assessment to be evidence for ADHD symptoms, which is not true. It is sensitive, but it is not specified to ADHD. So a neuropsychological test, it gives us clue about the attention deficit, but would not be specified for ADHD symptoms. Lab test also is not needed because it is not approved. Imagining an EEG study, there is a lot of overlap between depression and anxiety, ADHD on this result. Sometimes we use it if there is neurological deficit with ADHD. Education is very important. Before to go to the step of diagnosis and medication, we have to do education for the parent. Unfortunately, if the true ADHD in front of us, maybe we will face ADHD family also. The father is misdiagnosed and mother is misdiagnosed. So education about the chronic illness, how to deal with the chronic illness, how to diagnose, to be accurate diagnosis and take the step depending on this diagnosis is very important. The finding of this study find like 70% of children and young people, adolescent people with ADHD, they respond to stimulant medication, one of them. And the titration is very important to be related to the maximum efficacy with less side effect, not depending on or relying on the milligrams, because a lot of us in practice, we consider the milligrams more than to consider the efficacy and side effect. Again, medication plus psychosocial intervention and psychotherapy, behavioral therapy is very important than medication alone, and this is clear from the research, 2000, very old research. Medication only, we need higher dose to be effective. With psychotherapy and psychosocial intervention, less dose there. There is a lot of comorbidity with ADHD, like ODD, conduct disorder, reading disability, math disability, and anxiety and depression, abuse, alcohol abuse, and also in this research, 2011, they miss autism. We have to put priority for treatment because there is no ADHD alone, a lot of comorbidity there, mainly alcohol and substance abuse, mood disorder, bipolar, and anxiety. So we have to make full assessment for the patient because we consider what is the medication we have to give according to this assessment. This is a guideline everywhere. Still, US, they didn't have the specialized their guideline. Again, neuropsychological test, it's not enough alone to say this man or this girl, they have ADHD symptoms. Screening is very important, but it's also not diagnostic. This is very important screening tool, ASRS-5, which is very good tool to screen ADHD, and it's high sensitivity. If the level of screening is equal 14 or more, the sensitivity is 91% and the specificity is 96%, but again, it is not enough to diagnose. At the age of 7, before 7, child will come to us with attention. Most probably, they will come with comorbidity, the most common presentation between hyperactivity and attention deficit. Girl is more with attention deficit. We will face them if we will not diagnose them after 10 years, complaining from anxiety mainly, and complaining from borderline personality traits because of this lack of attention and the impulsivity. In male patient, if we missed by the age of 7 and not diagnosed, he will be more related to hyperactive type of attention deficit. Will we be changed to a lot of emotional dysregulation and impulsivity, and we will see later how it is affect the quality of life of our patient more than the attention and executive part of cognition itself. Rapid mood screening is very important to differentiate. There is comorbidity between attention deficit and ADHD and mood disorder like bipolar or depression, or it is part of the illness itself, which we consider it like deficit emotional self-regulation. This is the core of ADHD. This is not related to executive function, but it affects the quality of life of a child or adult more than a child. Impulsive behavior, mood dysregulation, the function and social life is very bad. Here are the two wings of ADHD, executive dysfunction and the emotional dysregulation. The executive dysfunction will affect the performance, and the emotional dysregulation will affect the social life of those patients. They can perform a little bit good, but because of the social skills deficit, they lose their job, they lose their relation, they lose the love and marriage. From this research 2021, we can see how much the emotional dysregulation affecting the quality of life of our patient. So how to treat? It is enough stimulant to treat this emotional dysregulation? We will see. We find moderate efficacy of stimulant and non-stimulant on the emotional dysregulation. So don't treat ADHD person with only stimulant or stratera, tamoxifen alone, because there is big part will be missed and affect the social and quality of life of those people. What is the treatment option? How to tolerate our medication for those patients to be effective and safe and to help them to improve their quality of life? Something very important, because it is a myth, and sometimes all of us, we do it in our clinic. If we are not sure about the diagnosis, we make trial to give a stimulant and see the patient if it's improved. It will be, will confirm the diagnosis, which is wrong, according to the guideline. The improvement on stimulants is not confirmed because there is 30% of adults, they don't respond at all to stimulant, all types of stimulant. And there is improvement can happen in depression, for example, in those patients, and it will be like misleading improvement. So please, we have to do good diagnosis. How to diagnose ADHD before to go to preparation and stimulant types? As we said, it is not a matter of neuropsychological assessment. We need to do good screening, and this screen is sensitive. Then we will go through full battery of assessment, good questionnaires, a lot of questionnaires. We can use it to identify the symptoms. As we know from the DSM-5, we have to diagnose a child ADHD by 6 out of 9 in both sides. Adult ADHD, 5 out of 9 on both wings of ADHD symptoms. Also very important to gather information from everywhere, from the family. If somebody come in adult stage and said, I have ADHD, you have to check the family, you have to take good history about the school. He was in one school and continue his study till he reach the high school and faculty. What is exactly his study? It needs good attention or no? He succeed in every year or no? What is the relation? He is in good relation and good term with his friend all his life, or he keeping change his friend and he is impulsive. All this history is very important to diagnosis, plus the questionnaires, plus the history from the family if we find any way to collect this information. This is the diagnosis. To reach, because this is very important, and comorbidity as the diagnosis is very important to reach the level which medication is good for our patient. There is 32 preparation from a stimulant. 7 of them now they are molecule in the market and we can use it. Maybe it's not all of them is available in UEE, but some of them is available and we can use it. And the response of stimulant is different. 41% of our ADHD patients, they respond for all equal for both type of group of stimulant, either amphetamine group or methylphenidate. 16% respond for methylphenidate and 28% respond for amphetamine group, and 15% they don't respond to any kind of stimulant. So we have still gap. We need more from medication, from a stimulant and non-stimulant medication. Methylphenidate is found more effective and safe for childhood ADHD. We can, on the other hand, from the guideline and from the research, amphetamine is more effective in older ADHD patients like adolescent and in adulthood patient, in adult ADHD. Genetic evaluation or genetic testing to differentiate between different type of ADHD and the best medication to use for treatment of ADHD. On the research on 2017, find the efficacy of this test 20% right now. By yesterday, I read about 2 papers in 2022. The efficacy reached 70% right now. But still, it is not evidence-based, and we can't rely on this kind of test, except it will be in guideline. This is a consequence of sequencing of giving the medication. If one patient comes to you, he has ADHD, what you will do? If your diagnosis is accurate, you have to give a stimulant. This is the first line of treatment. If he has an anxiety, give him a stimulant and treat an anxiety. If he has depression, give him a stimulant and treat depression. Only one situation, you better don't give a stimulant if the patient has history of drug abuse or susceptibility to drug abuse, so better to be away from stimulant medication. Choosing between methylphenidate and amphetamine, it's according to you, as I told before, better in childhood methylphenidate and better in adulthood amphetamine, and better in both form, long-acting form of medication. If the patient is okay with the medication, no need to add. If the patient has comorbidity, you have to treat comorbidity. If complain from insomnia or anxiety, you have to treat anxiety. If he complain from some aggressive behavior, also you can control. And we have some on-label and off-label medication to treat this kind of patient. A lot of debate in front of scientists and pharmacists to try to give us molecule. We can use it as a stimulant molecule also for addict patients without giving them the pleasure of addictive substance or to prevent them from use this medication as addictive substance. So the decision and process of this medication depend on compound, form of administration, duration of action, delivery system. There is now they try to find delivery system which is like subdermal or chewable medication to prevent them from crushing medication, for example, and use it by sniffing or use it as addictive substance. This is some types of medication available in the market worldwide to treat ADHD in childhood, and this is the doses. For example, atomoxetine, which is non-stimulant, and the dose, you can see in United States the dose is a little bit high than other dose range worldwide. Also, we can see Adderall, we can see Concerta, and some Ritalin with different doses, especially for adult and childhood. Non-stimulant like atomoxetine, now there is new medication, viloxazine and guanacine, and also clonidine, which is used, and off-label medication like bupropion, Effexor, and desibramine, and modafinil, and memantine. Latest ADHD medication, what is under process now to take the approval from ADHD to be treatment for, approval from FDA to be treatment from ADHD. We have now viloxazine. Viloxazine, it is a new medication. It is working in norepinephrine and dopamine and serotonin. It's strongly effective in ADHD, and a lot of trial done on this medication to compare the efficacy of this medication between 100 milligram and 400 milligram on treatment of ADHD, and they found it effective with common side effect for the same medication like somnolence and decreased appetite, headache, fatigue, and nausea, which is not so common. It's range from 0 to 10. A lot of research. This is efficacy. A new medication, also new form of medication, new update in stimulant medication, serdexamethylphenidate, which is increase the half-life of the medication to keep the patient stable and focused all the day, and decrease the drop will happen with other medication, which make him more in need to take another dose and something like this. So they find it is less addictive and more effective, and it is in the way to be approved from FDA also, and it is approved from the child from age of 6 to 12. The side effect is like other stimulant, headache, abdominal pain, insomnia, upper respiratory tract infection. And the pharmacokinetics is better than the other stimulant. If we compare it with regular methylphenidate, we can find it is not giving high peak and then suddenly to drop. No, it gives reasonable increase in the blood and go slowly to take all the day and give efficacy all the day. This is the dosage, 20, 30, 40. Also, amphetamine form, chewable form of amphetamine is now under process to take approval from FDA. It is that the half-life time is from 3 to 4 hours. Transdermal amphetamine also there. It is approved for the age from 6 to 17. What doesn't work? A lot of trial done on some medication which is fail, like Perivigan, and on some supplement, and this is a problem, a lot of supplement in the pharmacy claiming that it help ADHD, it help autism, it help whatever, but significantly there is no evidence-based medicine to say this medication is helpful. To summarize what we said about in this lecture, negative consequence of ADHD may be accounted for by executive dysfunction and emotional dysregulation. Use of ADHD screener is the first step to identify, not diagnostic, but it is the first step, and it's very sensitive to give us clue about what we will face as a patient with possible or ADHD. Understand algorithm on sequence, how to give medication, to give it in confidence and to give it in the benefit of the patient is very important. Latest FDA approval ADHD pharmaceutical include non-stimulant and stimulant. It will be very helpful, and it help us regarding prescribing medication without fear from being addictive. Thank you for your attendance.
Thank you, Doctor, for the engaging, comprehensive presentation. And for sure, I'll be taking your phone number for any challenging patient. So our next presentation is about autism spectrum disorder and update. Our distinguished speaker is Professor Mohammed Waqar Azim. He's Chair of Psychiatry, Child Psychiatry, Sidra Medical and Research Center in Qatar. He's a Professor of Psychiatry at Weill Cornell Medical College, Cornell University. He's Chair of Qatar's National Autism Plan Working Group and Co-Chair of WISH Autism Forum. Please join me welcoming Professor Mohammed.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. It's a pleasure to be in UAE. Thank you, Dr. Fatma, for the kind introduction. I will also like to congratulate my colleagues in UAE who invited me, Dr. Madad, and of course our WPA Executive Committee, Professor Afzal Javed, and others who are here. So thank you so much. It's wonderful to be here in UAE. I think it's my 5th visit here. So I'm here a number of times. So it's an important topic, and I will cover a few things. I know it's late, so I will try to be brief, but I will be available later on if folks want to talk with me further. So I have no disclosures to make. So our educational objectives today is to learn about prevalence of ASD, discuss salient features of ASD, and to explore various treatment interventions. I'm pretty sure some of you have seen children with autism, and this is probably pretty typical example. For example, Ibrahim is a 5-year-old child in 1st grade in regular school, referred for evaluation by school counselor because of issues in interacting with other children. At times in classroom, he's hyper-focused on certain things and toys. He has significant issues related with sleep. He never had any past assessments. So the first time assessment is sent to our clinic, I think must be familiar to you also. Second scenario, possible scenario. Khalid is a 14-year-old teenager referred by community physician for severe aggression and self-injury. He has diagnosis of autism and intellectual disability since very young age, so already have a diagnosis. He goes to special school. He has tried a number of psychotropic medications in the past without much benefit, mainly for aggression and self-injurious behavior. He has very limited speech and spends a lot of time watching cartoons. So this is another presentation you might see often in the clinics. Some of you probably have heard the name of Leo Kanner. Actually, it's interesting. This gentleman, originally from Austria, went to US initially in Dakotas and then later recruited by Johns Hopkins as a child psychiatrist and built the first child inpatient unit in 1935. So he first time described the children with autism, and there were 11 children. And actually, if you Google his name, you will find the paper. It's about 40-page paper, and he actually wrote about every single child in detail. And what he found, that these children were extremely aloof, there were delays in speech, and repeated certain patterns of play. But there are certain myths at that time in 1940s. He thought that most of these children are from higher socioeconomic status, and now we know it's not true. Secondly, he thought that most of these children does not have any medical issues. Now we know it's not true. A lot of these children do have medical issues. And he thought that most of these children have normal cognitive development. Now we know that's not true. A lot of children have issues with cognitive development. How many of you have seen these numbers? Came just recently, this year, I think a couple of months ago. Anybody want to raise the hand? Has anybody seen 1 in 36 number for autism? So it's interesting. Prevalence is a very interesting phenomena. So when you look at papers, you have to be very careful what that means. So these numbers are from US, might not be applicable to UAE or GCC or the Arab world. Why is that? So if you look at 1992, 1 in 150 children, and then it keep on decreasing, and now it's 1 in 36. But when you look at an abstract, you might not know how they calculate it. So basically, CDC has 11 to 14 states involved, and they look at 8-year-old children and try to look at who has autism features. So if they look at somebody in southern states like Alabama, the rate will be very low. It might be 1 in 200 or 1 in 300. But if you look in the northern states of US, the rate will be very high. And some people who know the systems in US, northern states like Boston, Massachusetts, Connecticut have higher amount of services available. So the diagnosis is a little bit higher versus the south where the services are not available. So I think that do play a part. Secondly, the rates are much higher in Caucasian. So the race plays a part, whether like if you think about in US, we know now that people who are African Americans and Hispanics doesn't get care as much. So the rates are much lower of autism in this population as compared to Caucasians. And then the rates are much higher in boys as compared to girls. So same goes in other countries also, but US is a big state. So take these numbers with big assault that it might not be applicable to UAE. So be careful when you quote these kind of numbers in Arab world. Actually, I was looking at UAE and I found some very interesting things. So UAE has Ministry of Community Development, and they say the registered numbers are 3,227 on their website. That I looked at a couple of days ago. So it's a pretty recent number on the website. And if you think about UAE, population is about 9.5 million, and the children are about 1.1 million. So this number, I think it's registered numbers, if I have to think, looking at different data, and there is one prevalence study done in UAE showing numbers of 1 in 146. So by that, it will be around 9,000 to 10,000 children who might have autism in the UAE. Familiar site, April 2nd, World Autism Day. If you go on to Burj Khalifa, you might have seen it in blue. It's a big day being recognized by United Nations in 2007 and celebrated all over the world. And I see a lot of news coming up about this day in UAE also. So why that's important? Because that tells about the awareness in the community, that community wants to raise awareness about this particular issue in the country. I think DSM-5 might have played a big part in increasing prevalence. The criteria is much looser and easier. And it's so easy to make a diagnosis, means much more rapidly. And what you look at is that there are deficits in social emotional reciprocity. For example, when the child come in from school, they might not be share what they have done in the school. They have lack of eye contact. It is their part of their story, and they might not be able to understand other people's part. They have reduced non-verbal gestures like finger pointing. They might not be able to do those kind of things. And they feel comfortable by themselves. So there's a difference. For example, sometimes I ask children, do they feel comfortable to be alone, or they want to be with other people, but they are so anxious or overwhelmed or worried or depressed that they don't have friends. So there's a difference. Although high-functioning autism can have more chances of depression because they have usually normal cognitive functioning, so they might like to have some friends, and they have difficulty in making friends, which can play a part in their mood symptoms. Then restrictive repetitive patterns of behavior, one of the diagnostic criteria, that they have repeated certain motor movements, like they might do hand flapping, walking on toes, or moving in circles. They might want things to be done in a certain way. Fixed interests. A lot of these children, I typically ask parents, do their children like to have cloth tags on the collar? They want it to be cut. There are a lot of children, when you ask, they have issues with the cloth tags. So a lot of issues with, for example, vacuum cleaner sounds, hypersensitive to sounds, light, or touch. Symptoms must be present in the early developmental period and cause significant impairment in social, occupational, or other important areas of functioning. So whatever, if you think about DSM-5, we focus a lot on symptoms, but not on functioning. So I think as clinicians, it's important that we should look at more functioning rather than symptoms. And when we look at improvement, we should think about improving the functioning of the child or individual rather than just improving the symptoms. In most cases, parents are worried in first year of life. In almost 90% of the cases, parents are worried by age 2. When you should be worrying about certain children that they might have autism or other developmental disorders, for example, if the child usually babble or make sounds in very young age, so if they're not babbling by age 12 months, or not saying single words by age 14 to 16 months, not having 2 words by 18 to 24 months, or any loss of previous language, you should be thinking that there is something not right. Intellectual disability used to be much common, but it is going down in children with autism. I think the reason most likely is that we do more early intervention, which plays a big part. 15 to 35% of the children have seizures, usually in young age or adolescence. A lot of children, actually in my practice, I see most of the children who have attention problems or hyperactivity problems. In DSM-4, we couldn't diagnose ADHD in autism, but now we can, although it is very different than typical ADHD. Most of these children have sleep issues or issues with food. There was a meta-analysis done of 9 studies, and very high rate of temper tantrums and self-injurious behaviors were found. As I mentioned before, these are some of the medical conditions we see in children or adolescents with autism, including Fragile X syndrome, tuberous sclerosis, neurofibromatosis, Down syndrome. So autism features are much more common in these conditions. Other thing which is interesting is children who have hearing problems or blindness might present with autism features, and it's very hard to diagnose autism in those children because they have issues related with their hearing and blindness also. You probably already heard that no scientific proof that vaccines causes autism. Usually vaccine is given around the same age when 1/3 of the children do regress between age 15 to 18 months. It's a very interesting study which was done at Yale, where they put a camera over here on the forehead, where you can track the eyes of the child where they are looking. For example, as you know, a lot of these children with autism does not have good eye contact. And yellow sign is the adolescent who is developing normally, and the green one is the child who has autism. So you can see an individual with autism looking at the mouth versus because his mouth is moving. This is a famous movie in 1960s. Elizabeth Taylor and Richard Burton was in it. So this was one when they look at the camera where they're looking. Again, red is autism, yellow is individual who is developing normally. So yellow is autism, very intense. Yellow, non-autism, very intense scene going on. So looking at the eyes, and the red individual who have autism. Very intense scene going on. So if you think about the yellow one is individual without autism, so it's intense scene going on, triangle, love triangle, that person is going back and forth between individuals versus red with individual with autism. Why is that important? So if you take eyes out of the equation of the face, 90% of your expressions are in eyes, not below the eyes. So one of the reasons the individuals with autism couldn't pick up the emotions of other individuals. So coming to assessment, I think the ideal is that it should be an interdisciplinary approach, which can have a child psychiatrist or a developmental pediatrician, child psychologist, speech therapist, occupational therapist, input regarding child in different settings, because what you see in your office, it might not be the whole story. Family input is the key. If I see one child with autism, I see one child with autism. Every individual is very different. And input from number of sources, especially the schools or special centers they go to. These are some of the scales which we use. Probably ADOS and ADI are the most standard, but I think, especially in US, Vineland Adaptive Behavior Scale is much more useful because it will tell you the function of the child rather than the disability. So it will tell you about what age they are functioning at speech, communication, motor skills, maladaptive behaviors. This is a study we did in actually Makkah, Saudi Arabia. And we have done this study in Pakistan and some other countries also. So it's available on website, in which we have a survey and we look at the knowledge of health practitioners, how much they know about autism. And we found that, as you know, we don't teach much in different disciplines about autism, and the knowledge was not much about diagnosis. A lot of practitioners go to medicines very quickly. A lot of people have hopelessness that these kids can't improve. So we need to have much more robust trainings in our medical field and allied health professional field to improve the awareness as well as the knowledge. Has anybody heard the name Stephen Wiltshire? No? So Stephen Wiltshire is originally from UK. He made this picture of St. Paul Cathedral when I think he was 13 or 14-year-old. Again, about 13 and 14-year-old. As you can see, this is a picture of New York. There is Statue of Liberty, so he made this picture. Anybody knows which place is this? Sydney. How about this? Dubai, Burj Khalifa. So one thing is very interesting. So you see a picture, there are a lot of streets and a lot of things. He's now 49. And what he do is, he goes on a helicopter or a chopper over a city for about a couple of hours. And then he goes into his studio. And he can draw every single detail of all the buildings and streets of the picture. So he takes 6-7 days, he makes the picture. So he has gone to most of the cities and draw these pictures. The reason I'm telling you this is one strength this individual has. I tell my trainees also and the people I train, 2 things to think about when we see children or individuals with any illness. One is, illness is one part of this individual. Every human being has strengths, and how we exploit those strengths is very important. I personally don't even use the word patients. Patient is about symptom and illness. People is about lives. Our role as clinicians is not to improve symptoms, but to improve people's lives. So think about it when you see people, not to just keep thinking about it's depression, it's ADHD, it's autism. Our job is to improve life of the people, not to just improve depression, anxiety, and that. So go a step further, think, is this intervention improving their school performance? Is it improving their peer relationship? Is it improving their other parts of the life? This is kind of a model I use for intervention in autism. The child and family are the expert, are in the middle, and everything revolves around them, whether it's behavioral interventions or ABA, speech therapy or language therapy. If I have to think about, is probably the most important interventions, because the earliest you do between age 3 to 5, the better the prognosis is on the long run. Environmental interventions, social skills. So a lot of people who come into our clinic says, this child is very good or adolescent is very good with younger kids or adults. The goal of social skills improvement is to be good with their own age peers, not with the older people or the younger kids. Educational interventions, I will come to that a little bit more. OT, a lot of these kids have sensory issues, and occupational therapy interventions can make a big difference. And medications are last resort, not a first resort, last resort. As I mentioned to you, early intervention is extremely important. It should be planned and intensive, should be interdisciplinary, that the goal should be individualized and teach the specific skills, and child engagement is central. Same goes for educational settings, that we should not have a standard curriculum for these children. These children require more individualized curriculum and interventions. Mentorship, how you help them to be in groups with other children that they can have more interactions, more structure, and be flexible. Has anybody heard me giving this talk before? No, probably, okay. Family. I do a lot of international consultations, and I was in Medina seeing a child, and the Saudi mother comes in. She has a number of children in typical dress, have hijab and abaya, and she wanted to talk about this child who is extremely aggressive and who's bouncing off the walls. And that is the mother, because they arranged for this consultation, very tough or complex case, if you can do something. And after first sentence, I asked the mother, how are you doing? And she was in tears. These children who especially have higher number of limitations, there's very high rate of depression, especially in mothers. And we focus a lot on children, not on the caregivers and parents. I have come to the conclusion over my practice over the years, the child with autism has a certain trajectory. You can make a dent up to a certain point. Keep working. But for parents and siblings, you can make a much bigger dent by providing them support or working with them how they work with this child. And their worries are very different than what you think. For example, what will happen when this child is 18 or 20? Marriage, college, when we are old, when we die, who will take care of this child? So they think very differently, and we have to be cognizant of that. We work with the family, understanding that this family, we need to spend much more time with the parents rather than the kids. As I was mentioning before, medication is a last resort. Usually we give medicines for repetitive behaviors and associated symptoms. So Dr. Fatma, I have 30 more minutes. That's what you said? How much? 5 more minutes. I will do it in 4.5 minutes. What do you think? Okay. When we use the medicine, so usually I talk about medicines the least because that is the easiest part. Anybody can prescribe medicines. The other things are much tougher. So medication, I have only one slide because medication you can read and it comes with experience. So for inattention and hyperactivity or impulsivity, stimulants is the first one to go, although if somebody have ADHD and autism, response rate is only 50% versus somebody who has straight ADHD, response rate is 70 to 90%. And these children are much more sensitive to stimulants. Aggression, irritability, risperidone and aripiprazole are 2 FDA-approved medication for this, done by RUP network. And I always tell at least my trainees, don't just pick a medicine. When you pick a medicine, you think about what is the evidence base behind this medicine. SSRIs for repetitive behavior, fluoxetine and fluvoxamine has positive studies. We sometimes think a lot about positive studies, not much about negative studies. The biggest study done with the repetitive behaviors in autism was citalopram. In 150 children, double-blind study was negative study. It was not effective. So I never pick citalopram in repetitive behaviors with autism. Anxiety, same SSRI. And insomnia, we use sleep hygiene and melatonin. So what are some of the predictive factors for outcome? Presence of communicative speech by age 5, absence of intellectual disability, and early intervention improves the prognosis. I'm working in Qatar since 2015, and I have traveled in most of the Arab world. And these are some of the things which we face probably in all over the Arab world. Lack of awareness, screening issues, timely screening, delaying the diagnosis, lack of evidence-based interventions, limited educational resources. There is not much resources in the schools. Transition to adolescence and adulthood is a big challenge. Limited training programs and lack of funding. Actually, I was hearing earlier presentation about mental health strategy of Abu Dhabi, which is great because those kind of things can make a big difference. It's interesting, there are very few countries which have national policy or national autism plan. UAE has a national autism plan. How well it's implemented, I'm not aware, but it has an autism plan which was established in 2021. And it has 5 pillars: diagnosis, healthcare, human resources, inclusive education, and awareness. I had the privilege to work and build the Qatar National Autism Plan in 2017, which took about 3 years. And people asked me what was the reason that we were successful in making a national autism plan. And I always say there were 3 things which made a big difference when you're thinking, putting a plan together at national level. That the country's top leadership is behind it. Secondly, all the stakeholders are on the table. And third, families are involved. If you have those 3 things, nationally you can make a lot of changes. Dr. Essen is here, who is my division chief for child psychiatry. These are some of the papers from my team in last few years. So in summary, we need a comprehensive assessment. Alliance with the family is extremely important. Child and family at the center of the treatment. Rule out any medical causes for behavioral issues. Incorporate behavioral approaches. Medication start slow, titrate slow. ASD more sensitive to side effects. Monitor impact on child and family. This is my team at Sidra Medicine in Doha, Qatar. And thank you so much. Right on time.
Thank you for being on time and for the interesting talk. Please join us. The floor will be open for questions. And Dr. Bassel. Yes, we are running a bit late, so we'll take 2 questions.
Thank you both for this interesting presentation. My question is directed to Dr. Bassel. Do you think the comorbidity with the ADHD of depression or of mood can be elevated by using only stimulants, or shall we think about something else? If stimulants like amphetamine or if like atomoxetine can help in depression, or we need to add on something?
Thank you. Thank you, Dr. Muhammad, for your question. But we have at first to differentiate between it is comorbidity or it is part of the illness. If it is comorbidity, we have to give medication for major depressive disorder or any kind of mood disorder as you diagnose. I think it will be not enough to give the medication for ADHD. And if it is mood dysregulation due to ADHD, we have to assess at first when we give the medication if it is solved, or we need to, for example, to add mood stabilizer or to add some other kind of antidepressant to control the